Mandibular Anesthesia, Injection Techniques with Dr. Morton Rosenberg, Professor of Oral and Maxillofacial Surgery, Head, Division of Anesthesia and Pain Control, Tufts University School of Dental Medicine, and Associate Professor of Anesthesiology, Tufts University School of Medicine. And Dr. Joseph A. Giovannitti, Jr., Professor and Chair of the Department of Dental Anesthesiology, Director of Anesthesia, Center for Patients with Special Needs, University of Pittsburgh School of Dental Medicine.
Blockade of the inferior alveolar nerve is the most commonly desired goal of mandibular anesthesia. It is also one of the most difficult blocks to achieve. Mandibular anesthesia depends on successfully blocking branches of the trigeminal nerve, especially the inferior alveolar nerve, which supplies mandibular teeth and surrounding soft tissue. The comparatively dense mandibular bone often precludes effective anesthesia from supraperiosteal injections with available agents, except perhaps in the incisor region. However, the inferior alveolar nerve is accessible before it enters the body of the ramus through the mandibular foramen. Deposition of local anesthesia in this area will produce conduction blockade. In this program, we will examine the three most commonly used injection techniques for mandibular anesthesia: the standard or classical inferior alveolar nerve block, the Gao-Gates mandibular nerve block, and the closed mouth or Akinosi technique. Our goal in this video is to increase your success in achieving profound anesthesia of the mandible. Local anesthetics are among the most effective drugs available. If deposited near peripheral nerves, they will produce reliable and predictable anesthesia. Mastery of clinical anesthetic technique, therefore, rests upon a solid understanding of anatomy.
Anatomy. The oral cavity receives innervation from the fifth cranial nerve, the trigeminal. A smaller part of this nerve is motor, while the larger part is sensory. The sensory portion forms a large half-moon-shaped ganglion called the trigeminal semilunar or Gasserian ganglion, which is situated in the trigeminal depression of the middle cranial fossa. Originating from the trigeminal ganglion are three large nerve trunks: the ophthalmic, V1, the maxillary, V2, and the mandibular, V3, the largest and the only one that carries both sensory and motor nerve fibers. The mandibular nerve passes through the foramen ovale down into the infratemporal fossa, where it separates into a small anterior and a large posterior root. The anterior root gives off motor branches that innervate the muscles of mastication. Then, as the buccal nerve, it crosses the coronoid notch of the ramus to innervate the cheek. Small fibers pass through the buccinator muscle to supply the buccal gingiva and mucosa in the posterior mandible. The posterior root of the mandibular nerve is predominantly sensory, although it does provide motor innervations to the mylohyoid muscle and the anterior belly of the digastric muscle. As it descends, it divides into three branches. The auriculotemporal nerve supplies the skin of the temporal region of the head. The lingual nerve provides general sensation for all of the lingual gingiva and the mucosa of the floor of the mouth and interior 2/3 of the tongue. In combination with a branch of the facial nerve, the chorda tympani, the lingual nerve also carries parasympathetic innervations to the submaxillary and sublingual glands and taste fibers to the tongue. The third branch of the posterior root of the mandibular nerve, the inferior alveolar nerve, passes through the mandibular foramen to enter the mandibular canal. Running forward in the canal, this nerve gives off branches to the teeth of the lower jaw and the surrounding alveolar bone. The mylohyoid nerve branches off just before the inferior alveolar nerve enters the mandible. It provides motor function to the mylohyoid muscle and the anterior belly of the digastric muscle. Also, it often innervates the skin covering the lower chin and occasionally provides sensation to the mandibular teeth. The mental nerve emerges as a lateral branch of the inferior alveolar nerve and passes through the mental foramen to innervate the interior buccal gingiva and the lower lip and chin.
All of the various intraoral injection techniques have one thing in common. The target site for assessing the inferior alveolar nerve lies within the pterygomandibular space. Detailed knowledge of the pterygomandibular space and the relationship of both its neuro and vascular components will help the clinician perfect mandibular anesthesia.
The pterygomandibular space, as seen in this transverse section across the ramus of the mandible, is bounded medially by the medial pterygoid muscle, laterally by the mandibular ramus, posteriorly by the parotid gland, and anteriorly by the oral mucosa, submucosal connective tissue, and buccinator muscle. Superiorly, it is defined by the lateral pterygoid muscle. Within the pterygomandibular space are the inferior alveolar and lingual nerves, the inferior alveolar artery and vein, and the sphenomandibular ligament. The inferior alveolar and lingual nerves enter the pterygomandibular space by passing between the medial and lateral pterygoid muscles. The lingual nerve follows a downward and lateral course through the space until it reaches the most anterior and inferior corner, where it exits into the floor of the mouth. The inferior alveolar nerve passes through the pterygomandibular space lateral and downward behind the lingual nerve, assuming a slight S-shaped configuration until it reaches the mandibular foramen. Armamentarium.
Patient safety and comfort rely on several factors, including the armamentarium used for local anesthesia, proper patient positioning, and the application of a topical anesthetic prior to injection.
When used correctly, the sterile single-dose cartridge, disposable hypodermic needle, sharps, and sterile aspirating syringe combine to ensure accurate placement of the local anesthetic solution with minimal risk to the patient. Proper handling and disposing of contaminated needles are important issues in the practice of local anesthesia. For mandibular anesthesia, the 25-gauge long needle is generally preferred. Advantages of this needle include ease of aspiration and accuracy of placement, as the 25-gauge needle resists deflection and breakage. Finally, the 25-gauge needle is no more likely to produce pain than thinner needles when inserted correctly. Topical anesthesia. To desensitize the mucosa before needle insertion, a topical anesthetic is applied to the injection site. The mucosa is first dried with a sterile gauze, and a small amount of topical anesthetic is then painted on with a cotton-tipped applicator. After the topical agent has had time to take effect, it will result in mucosal anesthesia to a depth of 2 to 3 millimeters. Residual anesthetic and surface debris are removed with a sterile gauze immediately before injection. Patient operator positioning. The proper position for the dentist and patient during the administration of mandibular anesthesia is similar for all of the injection techniques reviewed in this program. The patient should be placed in the supine position, with the legs slightly elevated. This position will avoid many of the psychogenic reactions encountered during the administration of mandibular anesthesia. For the right-handed operator performing a nerve block of the right mandible, the clinician should be seated in front of the patient with the patient's head turned to permit visualization of the oral cavity. For a right-handed operator performing a nerve block on the left mandible, the clinician should be seated behind the patient in the 11 o'clock position. The left thumb or a dental mirror is then used to expose the site of injection. Should placing the thumb in this manner prove awkward, the index finger may be used instead. Mirror images of these operator positions are used for the left-handed clinician. Injection Techniques Part 1.
A standard or classical inferior alveolar nerve block is used worldwide for producing mandibular anesthesia. The target for the inferior alveolar nerve block is the mandibular sulcus, just superior to the mandibular foramen and behind the lingula, a bony prominence on the ramus that anchors the anterior attachment of the sphenomandibular ligament. Deposition of anesthetic in this region will bathe the inferior alveolar nerve just before it enters the mandibular foramen. Intraoral landmarks are key to this injection technique.
The height of the injection is established by the greatest depression of the ascending ramus, the coronoid notch, a concavity on the anterior lateral border of the ramus. With the syringe held parallel to the mandibular occlusal plane and at the level of the coronoid notch, the needle will be in a plane that intersects the mandibular sulcus unimpeded. Because of the lateral flare of the ramus, the syringe must be advanced from the contralateral premolar region for the needle to enter the sulcus. Clinically, the coronoid notch is determined by palpating the most lateral aspect of the anterior ramus. Here, the thumb, kept parallel to the mandibular occlusal plane, is moved into position within the coronoid notch. A line bisecting the thumbnail establishes the height of injection. The insertion point itself is on this line just lateral to the pterygomandibular raphe, the soft tissue roll that denotes the junction between the buccinator and superior constrictor muscles and marks the medial border of the pterygomandibular space. The lateral border of the space can be determined by palpating the deep tendon of the temporalis muscle on the temporal crest of the ramus. The insertion must be made medial to this landmark. With the patient's mouth wide open, the thumb is placed over the anterior border of the ramus and pulled laterally, retracting the cheek and the buccal pad until it rests within the greatest depression of the coronoid notch and is made parallel to the mandibular occlusal plane. With the syringe oriented over the opposite premolars, the needle is advanced to the insertion point lateral to the pterygomandibular raphe and at the height of an imaginary line bisecting the thumbnail. The needle is then inserted slowly through the mucosa and buccinator muscle and into the pterygomandibular space. A few drops of anesthetic solution delivered as the needle is advanced may help reduce the discomfort of needle insertion. Once bone is contacted after an insertion of 2 to 2.5 centimeters, the needle is withdrawn slightly and an aspiration test is performed. After a negative aspiration, approximately 2/3 of the cartridge is injected at a rate not to exceed 1 cartridge per minute. If lingual nerve anesthesia is desired, it can be easily achieved by withdrawing the needle halfway and depositing the remaining third of the cartridge after a second negative aspiration test. The needle is then removed and the patient is allowed to rest for the 3 to 5 minutes it normally takes for anesthesia to develop. Long buccal nerve block. The long buccal nerve crosses the external oblique ridge in the retromolar area and provides sensory innervation to the mucosa of the cheek and the buccal mucosa and mucoperiosteum of the molar region. It often supplies accessory innervation to the molar teeth. For this reason, the long buccal nerve block is routinely performed in conjunction with the standard inferior alveolar and lingual nerve blocks. With the palpating thumb on the external oblique ridge, the needle is inserted 2 millimeters until bone is contacted. 1/4 of a dental cartridge is then injected. Injection Techniques Part 2. Occasionally, modifications of the standard technique have to be made to achieve a successful injection. For example, during insertion, the needle may prematurely contact bone. This may occur when the patient has a narrow face, when the insertion point is more lateral than ideal, or when the barrel of the syringe is positioned too posteriorly over the contralateral teeth. Regardless of cause, the needle tip strikes bone too anteriorly on the ramus and must be repositioned. The needle is partially withdrawn, the barrel is brought medially, and the needle is reinserted along the new path. Once past the obstruction, the syringe can be repositioned to its original orientation. In the patient where no bone is originally contacted after an insertion of 2.5 centimeters, there is the possibility that the needle tip is medial to the mandibular sulcus. Deeper insertion is not advised because of the potential for penetrating the parotid capsule and anesthetizing the facial nerve. Depositing the anesthetic at this point will still usually produce mandibular anesthesia. In the few instances when anesthesia is not obtained, perhaps because the sphenomandibular ligament and attendant fascia prevent lateral spread of the local anesthetic, re-injection will be necessary. To ensure that bone is contacted during the second injection, the insertion point can be moved slightly more lateral to the pterygomandibular raphe as the syringe is oriented over the contralateral mandibular first molar region. Then, when bone is contacted, gentle repositioning of the syringe and probing with the needle until it is felt to drop into the mandibular sulcus can be performed. Perhaps the most common cause for failure of the standard inferior alveolar nerve block is positioning the needle tip too far inferiorly. This can happen if the coronoid notch is not palpated correctly. For instance, if the thumb is too medial and palpates the temporal crest. Even if the notch is correctly identified, bisecting the thumbnail will misidentify the insertion point if the thumb is not parallel to the mandibular occlusal plane. These errors are more likely to occur in the patient who is missing posterior teeth. The prognathic mandible represents a special challenge because in this case, the greatest concavity of the coronoid notch is not predictive of the mandibular sulcus, which lies some distance superiorly. Therefore, in patients with class 3 malocclusion, the insertion point should be made 1 centimeter above the line bisecting the thumbnail. Gowgate's Technique, Part 1.
The notion that failure of mandibular anesthesia is often associated with inferior placement of the needle has led to injection techniques in which the needle is inserted higher within the pterygomandibular space. The most successful of these is the technique developed by Dr. George Gowgates. The target for the Gowgates injection is the neck of the condyle, just below the insertion of the lateral pterygoid muscle. In contrast to other intraoral nerve block techniques, this point is at least 1 centimeter away from the nerves of interest. Therefore, medial, anterior, and inferior distribution of the anesthetic agent within the pterygomandibular space is essential for anesthesia to occur.
The Gowgates injection is the closest intraoral technique to a true mandibular block. In addition to the inferior alveolar and lingual nerves, the buccal and auriculotemporal nerves are often blocked, the buccal nerve approximately 70% of the time. The position of the operator and patient for performing a Gowgates block of the left mandible is similar to that used for the standard inferior alveolar nerve block, except that the clinician must be able to view the patient's face, in addition to the oral cavity. The Gowgates technique relies on extraoral landmarks to establish the plane of insertion. With the mouth wide open, the angles of the mouth, the lower border of the tragus, and the neck of the condyle lie in the same plane. The needle is advanced in this plane just medial to the deep tendon of the temporalis muscle and through loose fatty connective tissue until it strikes the lateral neck of the condyle. Perhaps the most challenging aspect of this injection is determining the proper angulation of the syringe within the plane of insertion. According to Gowgates, the lateral flare of the tragus parallels the proper orientation of the syringe. Normally, the barrel of the syringe is placed over the contralateral canine. For a tragus that lies flat against the face, the syringe will be located anterior to the canine. With a divergent tragus, it will be posterior to the canine. The patient is requested to open maximally for this injection. External landmarks, the angles of the mouth, and the inferior border of the tragus are visualized and the plane of insertion identified. The flare of the tragus is also evaluated to determine the angulation of the syringe within the insertion plane. The cheek is then retracted with the left hand. For convenience, the thumb may be placed on the interior border of the ramus. The index finger may then be inserted in the intertragic notch and thus behind and lateral to the condylar neck to provide a tactile target for the needle. Gowgate's Technique, Part 2. With a syringe barrel over the contralateral canine and adjusted mesially or distally, according to the flare of the tragus, the needle is advanced through the mucosa just medial to the previously palpated deep tendon of the temporalis muscle. Normally, the insertion point is slightly distal to the maxillary second molar and at the height of its mesial lingual cusp. A few drops of anesthetic can be injected as the needle is advanced to the 2.5 centimeters until bone is contacted. When the needle impinges on the condylar neck, it is felt as a solid stop, in contrast to a glancing contact. Once the target is reached, the needle is backed off the condylar neck 1 or 2 millimeters, aspiration is performed, and the entire content of the cartridge is injected over a 1-minute period. The patient is then cautioned to keep the mouth open for 30 seconds after the needle is withdrawn. This maneuver is thought to help spread the anesthetic solution and minimize the distance from the injection site to the nerves of interest. Typically, anesthesia occurs within 5 minutes after injection. When properly performed, the Gowgate's block offers some advantages over the standard inferior alveolar nerve block. Because the anesthetic is deposited high up within the pterygomandibular space, it is less likely that various branches of the mandibular nerve, which may provide anomalous innervations of the mandibular teeth, will escape being bathed in anesthetic solution. Also, fascial barriers to anesthetic distribution may be less problematic than with the standard injection. In contrast to the inferior alveolar nerve block, however, anesthesia is unlikely to be achieved with the Gowgate's injection unless bone is solidly contacted at 2.5 centimeters, plus or minus 2 millimeters. Two reasons commonly account for failure to encounter bone at the proper insertion depth. First, the clinician may have positioned the syringe improperly within the plane of insertion. If the angle is too great or the insertion point too lateral, bone will be hit prematurely. It is also possible, though unlikely, that the needle will pass through the sigmoid notch of the ramus without striking any bone at all. Bone will not be contacted either if the angle is insufficient or the insertion point too medial. Correction involves ensuring that the point of insertion is just medial to the deep tendon of the temporalis muscle and appropriately reorienting the barrel of the syringe. For instance, if the insertion point is correct but bone is contacted prematurely, then the needle should be partially withdrawn and the barrel of the syringe moved mesially along the contralateral quadrant before reinserting the needle to the final depth. A second explanation for failure to contact bone is that the patient's mouth is not open sufficiently for the neck of the condyle to rotate downward and translate forward into the plane of insertion. If the patient cannot perform this task because of trismus, then the Gowgate's block should not be attempted. Instead, the closed mouth technique may be considered. Akinosi technique.
The closed-mouth approach to mandibular anesthesia, or Akinosi technique, uses the cleft between the ramus and the maxilla in order to access the pterygomandibular space. Although the target for injection is not well identified, there being no bony contact to indicate proper insertion depth, the needle ends up in the pterygomandibular space somewhat superior and medial to the standard inferior alveolar nerve block. The extent of intraoral anesthesia is similar to that of the Gowgate's block.
With the patient's head adjusted to facilitate visualization of the retromolar region, the cheek is retracted with the thumb to expose the insertion point midway between the ramus and the maxilla at the height of the mucogingival junction of the maxillary molars. With the syringe parallel to the occlusal plane, the needle is inserted posteriorly through the mucosa and buccinator muscle to enter the pterygomandibular space. As the needle is slowly advanced to its ultimate depth of 2.5 centimeters, a few drops of anesthetic can be administered to reduce discomfort during insertion. After a negative aspiration is obtained, the entire cartridge is slowly injected. Although the closed mouth technique is essentially a blind injection, it is technically easy to learn and of great advantage in the patient with limited jaw opening. It is also perceived by some patients as less stressful than the standard inferior alveolar nerve block, yet comparable in onset time and anesthetic efficacy. When failure does occur, it is usually caused by the needle being angled too medially. The maxillary mucosa is sensitive to abrasion by the syringe, as it is advanced posteriorly. In response, the patient may move to avoid the stimulation, or the clinician may adjust the syringe to improve patient comfort. In either case, lateral rotation of the syringe automatically forces the needle medially. A possible answer to this problem is to bend the needle approximately 15 degrees at the hub. Then the syringe can be kept off the mucosa as the needle is advanced posteriorly. Mental nerve block. The mental nerve may be anesthetized for procedures involving the chin and lower lip, the buccal mucosa and mucoperiosteum from the premolars to the midline, or to supplement an incomplete inferior alveolar nerve block. The target for the injection is at the mental foramen, situated just below the apex of the mandibular second premolar. Its location can be determined with the aid of radiographs and by gentle palpation in the buccal vestibule. For a successful mental nerve block, there is no need to penetrate the mental foramen with the needle. This injection is best accomplished with the clinician positioned behind the patient. The lip is retracted between the thumb and forefinger, and the foramen is located. With the tissue pulled taut, penetrate the buccal vestibule adjacent to the second premolar, advance the needle 5 to 6 millimeters, aspirate, and slowly deposit about 1/3 of the dental cartridge.
Successful and safe local anesthesia is the foundation of modern clinical dentistry. Only with a thorough understanding of local anesthetic techniques and their anatomical basis can we accomplish our goal of providing high-quality dentistry in a pain-free environment.